Okay, so welcome back to our ultrasound guided regional anesthesia workshop. Okay, so for our next module, we're talking about block for lower limbs. So our lower limb blocks can include plain blocks such as fascia, iliaca, or your nerve blocks like femoral and sciatic, adductor canals, and there are also PENG and IPACK blocks. So our next speaker hails from Hospital Kuala Lumpur, currently in his subspecialty training in regional anesthesia. He has worked in various hospitals prior, Melaka, Putrajaya, UMMC, and Kuching. Without a doubt, he has a special interest in regional anesthesia, as he is both a speaker and facilitator to various regional anesthesia workshops. Besides regional anesthesia, he has skills in ultrasound-guided vascular access and also contributes to postgraduate teaching for Part 1 Master's candidates. Welcome to the stage, Dr. Ng Zetek.
Okay, very good morning, Dr. Koo, Head of Department, the Anesthesia Department, Hospital Pulau Pinang, to the organizing committee. Thank you very much for inviting me. To all the participants, thank you for spending your Saturday morning, lovely Saturday morning, to come to this workshop. Sorry, Friday. I'm lost in time already. Friday, I thought it's Saturday. Thank you for spending this lovely morning here in this hotel to learn something. Hopefully, for those who have not done any blocks before, who are trying to learn, hopefully this will be a good platform for you to start. For those who have already do some blocks already, who are trying to improve their knowledge and skill, hopefully this will help you also. So today I'm going to talk about the blocks for lower limbs. Yep. So yeah, this will be the outline of my talk today. So for the purpose of practical purpose, I've divided the blocks to lower limb according to the blocks for hip surgery and also blocks you will commonly use for knee surgery. And not forgetting the popliteal and subgluteal sciatic nerve blocks. So yeah, lower limb blocks. Lower limb blocks. Actually, lower limb blocks in a nutshell is actually very difficult. Very difficult in a sense that you want to block the lower limb, it's not like the upper limb, you can just block the brachial plexus at various levels, then you can achieve anesthesia or analgesia easily. For the lower limb, the innervation of the lower limb is actually more complex. It's more complex. Each part of the lower limb, certain part of the lower limb receive various innervations. So you need to block more than one nerve in order to achieve the block. So the main thing about the lower limb is that it's innervated by the lumbosacral plexus. So yeah. So the lumbosacral plexus, it's the range is from T12 until S5. So it's wide, then various nerves comes out to innervate various part of your lower limb, whether anterior, lateral, posterior aspect. Each aspect might receive more than one innervation from this lumbosacral plexus, and maybe from various level. So you cannot just block one and expect everything to, unless you do a spinal or epidural. Yeah. All right. So this picture, a bit messy. I just want to illustrate to you how complex the innervation of the lower limb is. You got your dermatome, your myotome, and your bony innervations. So example, if your patient come in with a hip fracture, the surgeon want to do interlocking nail. They're going to incise the skin. Then you need to block the lateral femoral cutaneous nerve. But if they are going a bit higher, then you might even need to block the ilioinguinal nerve. Then you need to block the femoral nerve. And if they want to go through the trochanter, you might even need to block the posterior part, the sacral plexus, the sciatic nerve. So it's not just one injection for all. So yeah. So why not just do a spinal or epidural for all? Easy lah. So when in practical sense, yes, I admit even myself, you ask me to spend 1 hour to block the lumbar plexus, then the sciatic nerve. I might as well spend 5 minutes, just do one spinal, right? Why want to learn lower limb blocks? Yeah. So, but then again, sometimes in our current practice, sometimes your patient doesn't come in very simple, straightforward. Sometimes your patient come in with all these multiple comorbids. Some of them may be on chronic medication, polypharmacy, and one of that medication might be just a anticoagulant. Then gone lah. Then alamak. Patient on dabigatran, patient on rivoxaban, abis. Just taken this morning, alamak. Cannot do spinal, cannot do epidural. Lumbar plexus also I dare not do. Sciatic nerve also I don't want to do. But then, do we deny the patient block? Don't need to do block. So what is the role of block? So actually, in this, there's a paradigm shift in surgical and anesthesia practice. Actually, that blocks no longer play a role. It's just for anesthesia alone. It can, or sole analgesia alone. So there are, and then with the use of ultrasound, blocks can be safer and faster. And there are newer blocks being introduced all the time. And the role of blocks is not just for anesthesia or analgesia. It can be part of a multimodal analgesia. Yeah. So, now surgeons are going more and more minimal invasive. Some of them, they don't want, like your TKR, your THR, they want the patient to mobilize early. They're going minimal invasive. They don't want you to do central neuroaxial anymore. They want something that can promote early mobilization for the patients. And then to look at blocks, sometimes you need to blocks can now become part of multimodal analgesia. Yeah, and pain management is now more and more procedure specific. And blocks is just part of the equation. So it's a good tool now to just the good skill to pick up, because you can add value to the analgesia. Okay. So now we move into the blocks for hip. So we include femoral, LFCN, fascia iliaca, pericapsular nerve group block. So I just want to share with you this guideline actually. In Anesthesia 2021, this for hip fracture. Now this guideline says that actually you should offer a block to supplement your general anesthesia so that you can provide better analgesia for your patients rather than using just morphine alone or morphine plus NSAIDs. But sometimes NSAID we also very scared to use, or a morphine plus PCM. You can add in a block. And they actually recommend fascia iliaca because it's of the easier to be done, because now we got ultrasound. It's becoming easier. You can identify the plane easier. You can accurately place your needle in the plane. Then there's also this PENG block, but the PENG block, for your information, was just introduced in 2018. So there's lack of strong evidence. When I mentioned strong evidence is in the form of RCTs, there's lack of evidence, but doesn't mean that it doesn't work. This is another guideline for total hip replacement, because nowadays, like I said, we want patient to move, we want to promote early mobilization, we want motor sparing blocks. So again, looks like fascia iliaca is highly recommended. Yeah. So there is a role for blocks in our practice actually. So first of all, I'll talk about the femoral nerve block. Very basic block to be learned. Very easy and basic. So we are blocking the femoral nerve at the level of the inguinal crease. So this is the distribution of anesthesia or analgesia to the skin, to the muscle, and to the bone. All right. So typical volume is about 10 to 20 mils. You can achieve analgesia or even anesthesia if you. So about the femoral nerve, it originates from the lumbar plexus, L2 to 4. And at the level of L5, it exits the psoas muscle and moves laterally below the fascia iliaca. And at the inguinal crease, it will lie anterior to the iliacus iliopsoas muscle and lateral to the femoral artery. This is the landmark that we use to block this nerve. All right. So at the level of the femoral crease, the femoral artery lies superficial to the iliacus muscle and is covered by the fascia iliaca and lateral to the femoral artery. So this is how we look. So this is where we look for when we scan the femoral crease. We look for the femoral artery, and we look for the femoral nerve lying below the fascia iliaca, above the iliacus muscle. So it's not very deep. Yeah, it's about 2 to 4 centimeter. And of course, but the nerve looks a bit. It's difficult to see. Sometimes it's difficult to see the femoral nerve because it's a flat structure. Sometimes it looks like you can easily be. It's difficult to differentiate from the muscle. Sometimes you can miss it. You can think that it might look like a fascia. Okay. So how do you perform it? Usually, patient will be in a supine position with the lower limb fully extended, the hip slightly externally rotated, and you usually will use a linear probe, high frequency linear probe, and place it on the femoral crease. And the first thing you look for, the easiest structure to look for, is the femoral artery. Yeah. So because it's pulsatile, okay, and so anechoic means it's dark, and then pulsatile, easy to look for. Then, but sometimes, which level you want to, because the femoral artery there's a course, so you can see it like bifurcating into the superficial and deep. So which level you want to do? Preferably you do it at before the bifurcation of the artery, because the femoral nerve it start to branch out very early. It would branch out to saphenous and the nerve to the vastus medialis and all the other nerves very, very early. So you want to block you want to find the femoral nerve, you should go at where the artery is still as before the bifurcation of the artery. So neither approach is lateral to medial in plane. So you need to puncture the fascia iliaca because the nerve lies below the fascia iliaca. All right. So this is a picture showing the block being done. The sonor anatomy of the femoral nerve next to the artery, lateral to the artery, below the fascia iliaca. And this is the reverse anatomy to give you a better picture. Okay, the femoral nerve lying above the iliacus muscle, lateral to the artery, below the fascia iliaca. Next, I move on to the LFCN, lateral femoral cutaneous nerve. This is a very small nerve. Actually, it's just a pure sensory nerve. Yeah, so sometimes you wonder why should I block it? But it is useful sometimes if your surgeon is doing a lateral incision. Yeah, and sometimes by blocking it, you can save a lot of your morphine, fentanyl, Yeah, yep. So the distribution is just cutaneous distribution of lateral part of the thigh. So if your surgeon wants to incise, like they want to put a plate, they want to, it is, and being a sensory nerve, a small nerve, you don't need high volume. You just need 3 to 5 cc. You can go up to 10, but I think it's too much. So this is a very small nerve arising from the L2 to L3, and it emerges from the lateral border of the psoas and course underneath the fascia iliaca towards the ASIS. So at the ASIS, this is the landmark that we use to find the LFCN. So it passes at the ASIS, it passes underneath the inguinal ligament and travels distally over the sartorius muscle. So we use the ASIS and the sartorius as a landmark to find the LFCN. So it is under ultrasound, sometimes it's very difficult to see because it's just too small. Okay, very small. So you just see the structure underneath the skin surface between the fascia lata and the sartorius. You try to look for the first you look for the ASIS, then you track down, and then you see try to look for the sartorius and the fascia lata. In between them, you try to see a small hypoechoic structure that looks like a nerve. Yeah. So yeah, after identifying the ASIS, place the transducer in the transverse orientation, distal to the ASIS to identify the sartorius muscle. You just try to adjust till slide until to find the nerve. So this is the picture illustration to illustrate what I just meant just now. Below the ASIS, you find the sartorius and the tensor fascia lata. In between, or sometimes the nerve can travel into the sartorius also. So it's being a small nerve, it's very difficult to be identified. But remember, it is very superficial, just underneath the skin. Okay. Next, I move on to the fascia iliaca compartment block. So is there a way people think where we can block both the femoral and LFCN or even the obturator nerve all together? Even will it be easier? Or some people want to think, I want to block the lumbar plexus, but I don't want to do it the conventional way. I want to do it another way. Can I approach the lumbar plexus from the anterior side? So that's why they come up with this fascia iliaca compartment. It's a compartment block, fascial plane block. So you're trying to block the all three nerves under the fascia iliaca. So being a fascia compartment block, you need a high volume, typical volume 20 to 40 mils. Yeah. All right. So this is the distribution of the block. Basically, it's similar to the distribution of femoral, LFCN, obturator combined together. But most of the time, the obturator is easily missed because of the anatomy. All right. So the fascia iliaca covers the iliacus muscle from the pelvis up to the upper thigh. So the LFCN emerges from the lateral border and travel underneath the fascia iliaca. This is the problem. The obturator nerves emerge from the medial border of the psoas muscle and travel posteriorly. So it's like a different compartment. So most of the time, obturator nerve is very difficult to be blocked. This is a picture to show the anatomy of the fascia iliaca. Okay. So the evolution of the fascia iliaca, actually fascia iliaca is not a new block, it's nothing new. Even in 1973, people start doing it already. They coined the term 3-in-1. We want to block all three nerves, femoral, LFCN, obturator, using one single injection. So they use the ASIS and pubic tubercle as a landmark. And they just put middle or lateral third. Then they modified in 1989. It was modified to the lateral third injection. Then it's not until 2008 until we start use the ultrasound to identify the fascia iliaca. But that also, first they put the probe at the infrainguinal region. Then 2011, Herbert introduced the suprainguinal approach. And 2017 was Desmet, the author, modified it a bit, rotate a bit, and describe the bow tie sign. All right. So this is the evolution of it from being a infrainguinal, just next to like what you do a femoral nerve block. You identify the femoral artery, femoral nerve, fascia iliaca. Then you just give the injection at this point, lateral. Okay, that's the infrainguinal. Then you did the suprainguinal one. They just move the probe above the inguinal ligament and rotate it slightly. Then you get this suprainguinal view, the bow tie sign, the bow tie, part one of the bow tie being the sartorius, the other part of the bow tie being the internal oblique and transverse abdominis muscle. Yeah, so this is what I meant by the bow tie sign. But you need to identify the anterior inferior iliac spine, not the anterior superior iliac spine, anterior inferior iliac spine, iliacus muscle, sartorius, and internal oblique. Looks like a bow tie. All right. So how do we scan to look for this? So the transducer is initially placed now this is the infrainguinal approach. Infrainguinal approach, you just put the transducer at the transverse orientation at the femoral crease, distal to the inguinal ligament. So you inject in plane, lateral to medial. Okay, and pierce. You must pierce through the fascia iliaca, and you observe the spread of the LA, lateral to medial, cranial to caudal, and separating the fascia from the muscle. This is the problem with fascial plane block. Another problem with fascial plane block, what is a good spread? Good spread, and does good spread result in good analgesia? Yeah, you need a good, but at least you must see the spread. You must see the separation of the muscle and the fascia, not injecting into the muscle. Sometimes injecting the muscle will not get good effect. So this is the pictures of infrainguinal, just like the femoral nerve block. Okay, but you inject lateral, you don't target the nerve, you target the fascia. And observe the spread. Using high volume, you see the spread laterally, cranial-caudally. So, but the next is the suprainguinal approach. How you do the suprainguinal approach? So, first of all, you must identify the ASIS. And you just place the transducer medial to it. Okay? We find that this technique is a bit easier. You just identify the ASIS and you just slide your probe medially and rotate a bit to get that orientation. You rotate your probe and in the orientation perpendicular to the inguinal ligament. Okay? And then you slide your probe caudally, medially, until you identify the anterior inferior iliac spine. So how to differentiate? Anterior superior iliac spine is at the superficial, very superficial, it's near the skin. Anterior inferior iliac spine is below, lower, deeper at the muscle. Then you identify the bow tie sign. Okay? This is we use in plane. This one we use caudate to capsulate injection because we want the spread to go up to capsulate. All right. So you still pierce the fascia iliaca, but at the most superficial part of it, above the AIIS, preferably And you need to spread the LA deep to the internal oblique and transverse abdominal muscle, hoping to catch all the LFCN, femoral at its original course when it course out from the lumbar plexus into the iliacus muscle, into the psoas muscle, into the iliacus, hopefully to catch that. So this is the picture illustrating how we do the suprainguinal fascia iliaca block. So this is the bow tie sign. So you inject here above the AIIS. Right? So what's the difference? Some prefer to do supra, some prefer to do infra. Why? What's the difference? Actually, the analgesia efficacy of fascia iliaca block depends on the spread of the LA, how far it can spread. So that's why the suprainguinal approach result in better spread to all three nerves. But you need high volume. Okay, in this study published in Regional Anaesthesia Pain Management 2019, on 10 healthy volunteers who received bilateral fascia iliaca block. One side they do infra, one side they do supra. So they use 40 cc. So the primary endpoint is complete sensory block of medial, anterior, and lateral part of thigh. So supra result in 80% of this complete sensory blockade, while infra only 30%. Okay. This is another study to illustrate how much volume you actually need to cover the LFCN and the femoral and obturator. Actually, this is a cadaver study on 36 cadaver using dye. And they find that in order to stain the femoral LFCN obturator, you need about 60 mils of LA. So yeah. So in conclusion, fascia iliaca block is a facial plane block. Facial plane block, you need volume. You need volume, you need to cut down your concentration because you want to prevent LA toxicity. Okay, so typical concentration we use for facial plane block, 0.3% ropivacaine. Okay. Next, I move on to a newer block. This one, like I said, PENG block introduced in 2018. Yeah. So why do some people want to, why do they come out with this block? It's because we want to target hip pain. We want to treat patient with hip pain. We want to, a lot of patients come in with hip surgery, for fractured hip. We want to treat their pain. Okay, so this is another option, another option. So the innervation of the hip joint is very complex, very complex. You got contribution from femoral obturator, superior gluteal, inferior gemellus, and sciatic. So if you want to achieve analgesia for the hip, do you block all of them? So this study actually is trying to, what is this study trying to do? It's trying to say that actually for the hip joint, you don't need to block all the nerve above to achieve analgesia. The majority of the pain fibers, mechanoreceptor, are concentrated at the anterior part of the joint, And the anterior part of the joint, the main nerve you need to block is femoral nerve, obturator nerve. And in certain population, not everyone are not, accessory obturator nerve is not found in the majority of a population, but some population have this accessory obturator nerve. But these three nerves are the nerves that you need to block. So yeah, this study actually published in 2018. They want to try to, they use it's a cadaveric study to try to identify where are all the, what are the innervation of the anterior. We know that, and we need to focus on the anterior part, anterior capsule, anterior part of the hip joint to treat hip pain. So what are the nerves there? So they find that actually, the femoral and obturator, and to a certain extent, accessory obturator is present in the anterior hip joint. And another thing that they found that is that the articular branch of these three nerves are all converged in this inferior medial acetabulum. They're in between this space, the space between the anterior inferior iliac spine and the iliopubic eminence. It means that all these three nerves can be potentially blocked if you put a needle at a space between the anterior inferior iliac spine and the iliopubic eminence. So this is the space that they found. If you put the needle there, inject LA there, you can potentially block all the three nerves that innervate the anterior hip capsule, and you provide analgesia for your patient. So then they come out with this PENG block. Okay? So how do we get this? How do we scan this area? So because it's inside the pelvis, it's a deep structure. Unless your patient is very thin, muscle wasted, then you can use a linear probe, high frequency, because high frequency linear probe doesn't penetrate well into tissue. So you need for normal patient, you need low frequency ultrasound probe, 2 to 5 hertz. Okay, you place it at to visualize the iliopectineal eminence, the psoas muscle tendon, and the femoral artery and the pectineus muscle. All right. So how do you get that? There are two techniques that have been described before. The first technique is to identify the AIIS. So how do you identify the AIIS? Actually, you can't, because it's a deeper structure. So you can only palpate the ASIS, and then from the ASIS you trace down and to look for the AIIS. Then you rotate your probe to align the transducer with the pelvic rim. So this technique is a bit difficult. So then comes the other technique. You just place the probe over the femoral crease in an oblique orientation, parallel to the inguinal ligament. At this level, you will identify the head of femur. Then you just slide your probe cranially until you visualize the surface of the iliopsoas notch, which is where the iliopubic eminence is. Okay. Then you place a needle in the musculofacial plane between the psoas tendon and the pubic ramus. Typical volume is 20. Yeah, like I said, this vlog was introduced in 2018, so we actually still don't know, but the case series that they introduce, they typically use 20 cc, and they find that it works. So this is the picture that you just place your probe over the femoral crease to first identify the head of femur, then you just slide your probe cranially and apply some tilting, then you will see this nice line. You guys see the femoral artery, the iliopubic eminence, anterior inferior iliac spine, psoas tendon. So this is the space of the PENG block, right? Okay, then you just place a needle. Yeah, of course, you need to place the needle in the musculoskeletal fascia below the tendon. All right. Okay. Okay. So far so good. Okay. All right. Next, I move to the blocks for the knee surgery. So blocking the knee now. So mainly for this part, I'll talk about the adductor canal and the IPACK block. So we all know you want to block the knee, or you want to provide analgesia for the knee. The gold standard is femoral nerve. Yeah, gold standard is still femoral nerve, but now, blocks are being part of multimodal opioid sparing technique, and because your surgeon want your patient to early mobilize, and then early mobilization, when they want you cannot have too much muscle weakness. If not, the patient will fall. So for all those reasons, now for knee, they are moving away from this femoral nerve block. The trend is to move, unless your surgeon is still very conservative. They don't move your patient after 2-3 days after surgery. I don't know, but yeah. So nowadays they're moving away from femoral nerve block more towards this more peripherally. So the adductor canal block. So where is the adductor canal? This is a very controversial thing. Anatomically, people use the midpoint between the ASIS and the base of the patella as a landmark for the adductor canal. But this one has resulted in a lot of argument. People say that no, actually that is the femoral triangle. So, yeah, because previously, how do we know? We don't even have an ultrasound. We don't even know. We don't dissect our patient, so we don't know. So we just use the midpoint between the ASIS and the patella. There, they inject there. That's the adductor canal. But a lot of people say no, that's the femoral triangle actually. Yeah. So this is to help you to illustrate the issue here, So your femoral triangle is actually formed by the inguinal ligament, sartorius, and your adductor longus. So if you strip away your sartorius, you find that actually your adductor canal is only here only. So that's the argument. That's the argument. All right. Yeah. So the concept of this subsartorial region, yeah, you have the sartorius and the adductor longus and the vastus medialis will all come together in the subsartorial region, but only part of it is in the femoral triangle, and the other part of it is the adductor canal. So why are some people so particular? Because they argue that if beyond this, below the femoral triangle, there's only the saphenous nerve. Above this, inside the femoral triangle, there are other nerves that you block that also contribute to the knee joint, like nerve to vastus medialis, for example. All right. So how do you actually define the adductor canal under ultrasound? Now with ultrasound, we can see the muscle already. So then they start to define the muscles under ultrasound. So when you scan, you follow the sartorius muscle. Then you see the vastus medialis and the adductor longus. So when the medial border of the sartorius, this is lateral, this is medial, the medial border of the sartorius muscle and the medial border of the adductor longus. So you see sartorius come from lateral to medial, adductor longus from medial to lateral. So if the medial border of the sartorius muscle meet the medial border of the adductor longus, that is the tip of your femoral triangle, tip. So means the apex, means the end of the femoral triangle already, no more. Below that is not the femoral triangle anymore. Below this point is the adductor canal. So they describe this sign like a purse slip, something like that. Okay? Like a purse slip, called a kissing sign. All right? So you look for that to differentiate. Under ultrasound, you try to look for that to differentiate. So, Why do we need to bother? Why do we want to bother to whether I do femoral triangle, whether I do adductor canal? So what? So what? Huh? So there is an argument. There is an argument that if you only do the adductor canal, you're only blocking the saphenous. There's this subsartorial plexus, a group of nerves, including the vastus medialis, which innervates the anterior medial side of the knee joint. Sorry, is outside the adductor canal. So some people argue that you give adductor canal alone will not provide good analgesia for your patient. But then this study disagreed. This study said there are 20 cadaver dissected, and they said both saphenous nerve and nerve to vastus medialis were constantly identified in the adductor canal. So then they can argue back with, did you define your adductor canal correctly? So difficult. A lot of argument, a lot of controversial. But in practice, we know that if you inject your LA under the subsartorial region, which include the femoral triangle and the adductor canal, both. So we know is the proximal injection will result in more spread to the femoral nerve. It will cause more motor weakness, but probably maybe better analgesia. The more distal you do, less risk of less motor weakness, and possibly spread beyond the adductor hiatus. You know that you're beyond the adductor hiatus, at the end of the adductor canal, the femoral artery is going to move posteriorly to become the popliteal artery at the hiatus. And if you inject distally, the LA might follow this path to the posterior part of the knee and innervate the posterior capsule of the knee, which is also might be beneficial for the patient, especially those undergoing total knee replacement. Some of them might have posterior knee pain. Yeah? Yep. So how do we scan? So one technique is you can just trace the sartorius proximally and distally to identify the landmarks that define the apex of the femoral triangle, like I showed you just now, that kissing sign. Then inject beyond this point, you're doing a adductor canal block. So usually we do a lateral to medial injection towards the fascia of the sartorius and lateral to the femoral artery. So because we think usually the saphenous nerve will be next to the femoral artery, lateral to the femoral artery. Which again, there are anatomical variation. It can be medial, it can be lateral. So typical volume is 20 mils. So this is a picture to illustrate the adductor canal. So there's no kissing sign here. The sartorius, medial border of sartorius and the medial border of the adductor longus no longer meet. All right. So this is the picture to illustrate it. So your needle come in from lateral and you place your needle next to the femoral artery. Okay, volume, does volume count? Yeah, yes. Actually, there are some papers that shows that the higher volume you give, the more motor weakness you get. All right. And yeah, come to the problem, same thing. Where you inject, does it matter? Does it matter you do femoral triangle? Does it matter you do adductor canal? Does it matter? So this paper published in 2019. Okay. So 150 patients undergoing TKR randomized to receive catheter midpoint of femoral triangle, which is 2 cm below the apex of the triangle. They compare this adductor canal and okay. So they compare these two groups, adductor canal versus femoral triangle. They find that there's no difference. Again, another paper, optimal location for the catheter. This paper, they put 3 different sites, but never mind, let's focus on A and C. A is actually inside the femoral triangle, and C is actually inside the adductor canal. So they find that there's no difference in the analgesia, pain score, morphine requirement. So now there's a new concept said, why not we block both? Why not we block both sides? Why not we block both the femoral triangle and the adductor canal? Why not we just do 2? right? To provide better analgesia. So since you argue that if you go adductor canal, less analgesia, you go femoral triangle, more analgesia, why not you block both? So that comes this term. You find the apex of the femoral triangle here, kissing sign again. So you move 2 cm away, maybe you inject 10 to 20 here. Then you move 2 cm below, you inject 10, 20 cc here. Yeah. And then they find that, yeah, this is the coverage of the coverage of that block. Okay. So, but still we are missing the posterior side. We're still missing the posterior capsule. So if your patient have posterior, what happened? Why? How? If your patient got posterior knee pain, how? There comes the IPACK. Yeah. So the posterior part of the knee is innervated by branch of the tibial nerve. So whenever you block femoral nerve, also useless because it's by the tibial nerve, which is part of the sciatic nerve. But then some surgeon will not like if you cause a foot drop in your patient, in their patient, and their procedure might cause foot drop also. So is it caused by the surgeon or caused by us? So that's why this block came out because they want to provide good analgesia but motor sparing. Okay, so the first technique they describe is you put a probe over the popliteal crease to visualize the femoral condyle. So the femoral condyles are discontinuous curved hyperechoic lines, and then you also can identify the popliteal artery, which is an easy target, easy structure to identify, pulsating and echoic structure. Then from this point, you move your probe carefully, okay, until you see the femoral shaft. From the condyle become the shaft. So this is the place where they postulate that the tibial nerve will branch out to the articular branch, will give rise to the articular branch to the posterior capsule of the knee. Okay, so from there they inject, they place a needle in plane medial to lateral. So the insertion point is parallel to the femur, and you place your needle, you tip 2 cm beyond the lateral border of the popliteal artery, and you inject up to 20 cc of LA. It's also considered like a plain block. Yes, you are targeting nerves, but you don't need to visualize the nerve. You put LA in that tissue plane where most likely the nerve passed through and to articulate the knee capsule, posterior knee capsule. So this is the picture to illustrate. You put your patient in the prone position or whatever position, but your probe is posterior. Okay, in the first position is at the popliteal crease. Then you slide upwards until you see the femur bone. Then you just inject between the artery and the joint capsule. But then they've modified that technique. They modified it. So now the technique is you put the patient in the supine position with the hip abducted and externally rotated. You use a curvilinear probe, not a linear probe anymore, and you place the probe over the lower third aspect of the medial aspect of the thigh. And you try to visualize the femur and the femoral vessels in the cross section. Then you trace caudally, trace it down until the femoral artery dives into the popliteal fossa. Like I said just now, from the adductor canal to beyond the hiatus, the femoral artery will become the popliteal artery. So this is the area where they are scanning. So you visualize the space between the popliteal artery and the shaft of femur. So you insert the needle in plane, medial to lateral also, same thing, medial to lateral. Same thing, you place the tip of the needle 2 cm beyond the lateral border of the artery and inject 20 cc of LA. So this is the technique that they are using now. So you use a curvilinear probe, place it in the thigh, medial aspect of the thigh. You visualize the femur. This is a transition between the adductor canal to the adductor hiatus to the popliteal fossa. So you move your probe in this direction, and then they'll transit from adductor canal down to the popliteal fossa. Then you inject between the popliteal artery and the femur. Okay. All right. Okay, so far so good. So we covered the hip and the knee. Now to the sciatic nerve. So sciatic nerve, so nothing new, nothing much, just conventional, very conventional. So sciatic nerve origin from the lumbosacral plexus, L4 to S1. So it exits the pelvis through the greater sciatic foramen below the piriformis muscle. And it courses in the fascial plane below the gluteus maximus and descend into the posterior thigh between the greater trochanter and ischial tuberosity. Why we need to know this? Because previously without ultrasound, very difficult. The landmark you need to palpate the greater trochanter, posterior superior iliac spine, all this palpate, that, then draw this line, that line, inject, because we want to identify the nerve between the greater trochanter and the ischial tuberosity. We want to precisely place the needle next to the sciatic nerve to block it. So that's why previously landmark technique, you have to draw this, draw that, identify this landmark, that landmark, cross. So the sensory and distribution for the subgluteal sciatic block is, this is as shown as in the illustration. Noted that this part is missed because the posterior cutaneous nerve branches out very early inside the gluteus maximus, inside very early. So that's why sometimes you find that it is missed even you use a subgluteal approach. So for this, you need the patient to be in the lateral decubitus position with the hip and knee flexed. You need to flex to make it more superficial, to make the nerve more superficial. Okay, so you identify the lateral prominence of the greater trochanter and ischial tuberosity. These are the two landmarks that you need to identify, and you need to use a low frequency curvilinear probe for better penetration. And you place the probe between these two landmarks. Okay? So what are you trying to identify? You are trying to identify the subgluteal space. The subgluteal space is a area between the gluteus maximus and all the muscle below it, one of it being the quadratus femoris. Okay? And sandwiched between this is the sciatic nerve. Right? So this is the ultrasound view of this subgluteal space. Okay, the greater trochanter, the ischial tuberosity, between this, sandwich between the gluteus maximus muscle and the quadratus femoris muscle is your sciatic nerve. Okay, easier said than done. Most of the time, it's very difficult, even under ultrasound. So you need a long needle also, typically 80 to 100 mm. You do an in-plane technique, lateral to medial injection. So typical volume is 20 mils of LA. So what are you trying to see? You're trying to see the expansion of the subgluteal space. Okay? You can use a peripheral nerve stimulator in this case because sometimes you really cannot see to help guide you to the placement of the needle. So this is a picture to illustrate the subgluteal space after LA has been injected. So you are injecting in between the gluteus maximus and the quadratus femoris in order to catch the sciatic nerve. All right. So, so finally, I'll talk about the popliteal sciatic nerve block. So this actually is for foot and ankle surgery, foot and ankle. So the coverage is as shown in this illustration. So what is the aim? The aim is actually to inject LA into the sheath that contain the sciatic nerve and its branches, which is the tibial nerve, common peroneal nerve. Typical volume, 15 to 20 cc. So we know that when the sciatic nerve descends through the posterior compartment of thigh, at about 2 to 4 cm above the popliteal fossa, it will divide into the tibial nerve and the common peroneal nerve. But both of these nerves are enveloped by a common connective tissue. So this is the basic of this block. You need to, So first of all, you place your probe at the popliteal crease. The popliteal to identify, easy target, popliteal artery, popliteal vessel. You can see it between the condyles of the femur. And usually the tibial nerve is easily identified. Posterior to the vessel and slightly lateral. So the common peroneal nerve is a bit more lateral, and because it's smaller and it's anterior to the tendon of biceps femoris, at this level, usually the tibial nerve is easier to be identified. But then again, you just move your probe capsulet, slide your probe capsulet, and then you can see the common peroneal nerve and tibial nerve as individual structures, and they come together and join together. So after the nerve converge, join together, you'll form the sciatic nerve, and then it will enter the biceps femoris. So when it enters the biceps femoris, it becomes very deep. So at this point, probably most of the time, you can't see the nerve anymore. So this is what I'm trying to say at the popliteal crease. You said two individual nerve, then they join together, and then they go deep behind the bicep femoris. So this block you can perform with the patient in the supine, prone, lateral position. Okay, you can use a high frequency linear probe, and you start at the popliteal crease. Then you identify the structures, and you tilt. One of the technique to help you identify the nerve is to tilt the probe caudally. Okay, and then it's an in-plane lateral to medial injection. Typical 20 mils of LA. Okay, so yeah, this is a common position we do for popliteal sciatic nerve blocks. And this is the picture to show the block being performed. All right, this is the reverse anatomy. Okay, these are my references. Okay, thank you.
Okay, thank you, Dr. Ng. So now we'll open the floor to any questions. To our online participants, you can also ask questions in the chat box and we shall read it out for you. Okay, so there's a question from our online participant. So for the second updated IPACK technique, do we just deposit all 20 mils LA at one place, or do we do it in aliquots, 3 mils aliquots, as the needle is withdrawn from the lateral condyle?
Yes, for the other technique, also you inject in 3 cc aliquots and withdraw your needle. That's because you are trying to target a space. So yeah, not targeting one place. Because you know that the tibial at that place, that space, the tibial nerve will give out its articular branch to the posterior knee capsule. So, but that space is quite a large space. So you don't deposit all your LA in one space. So you inject, place your needle tip about roughly 2 cm beyond the artery, and as you withdraw, you give the LA to spread the LA in that space. Yeah.
I hope that answers the question. Okay, any other questions from the floor?
Good morning, Dr. Ng. May I know for fascia iliaca block, if I target the landmark for just anywhere along the spine of the pelvis instead of just focusing on the AIIS, is it possible to deliver the fascia iliaca as well?
Yeah, very good question. Yeah, so this is where you mean that if you move around the pelvis, means if your probe is placed too medial or too lateral, does it get the effect? You're still underneath the iliacus. You're still above the iliacus muscle. Sometimes if you put your needle, you place your probe too medial, sometimes you might miss the fascia actually. Yeah. And too lateral also, you might miss the fascia. The spread might not be as good as that described as above the AIIS. Yeah. One technique I use to confirm my injection is that I see the spread to the infrainguinal area. So after I give the block, I'll scan the infrainguinal area to see whether does it spread to the femoral nerve or not. Infrainguinally lah. With the classical, you scan the classical femoral. If you see the LA spread above the femoral, between the femoral nerve and the fascia iliaca, then means it's a success lah. Yes, I know sometimes the suprainguinal area is very difficult to identify. Very difficult. Sometimes in elderly patient, the muscle and the fascia doesn't all look the same. You cannot differentiate. But you look at the AIIS as a landmark. It's actually an easy landmark. Yeah. So if you but if your probe is too medial, sometimes your LA doesn't follow the iliacus muscle. So that's the problem lah. And if you put your needle too lateral, it might not spread also. Yeah. So better to put it at the level of the AIIS. Yeah. So that's why I introduced both technique, infrainguinal and suprainguinal. So that actually if you really have problem identifying the suprainguinal fascia iliaca, like actually sometimes when I do block also, especially when I do post-operative block, when the surgeon has already incised the posterior lateral aspect of the thigh, the whole suprainguinal area has a lot of air inside. So air is an enemy of ultrasound. So you put the ultrasound there, you only see white color thing. Everything is white. You cannot differentiate the muscle. You cannot differentiate the fascia. That's why if you really have problem, then you revert back to the infrainguinal technique. If you cannot see the infrainguinal technique, then just go to a femoral nerve block. So for hip, there are actually a lot of options. You don't have to necessarily, if you cannot do suprainguinal, means you don't offer any block. No, not necessary. Yeah, there are so many options. You can do PENG, you can do fascia iliaca. And fascia iliaca, if you cannot really have problem with suprainguinal, go infrainguinal. You really have infrainguinal also problem? Femoral. Okay? So just the reminder that if you do PENG block for surgery per se, it doesn't cover the incision point. It depends on where your surgeon incise. So yeah. So it incise at the lateral aspect of the thigh, you need to block the add in the LFCN nerve block because it will help with the skin incision site. And sometimes like in HKL, we have our surgeon doing the acetabulum repair. They use the inguinal approach. They don't do lateral approach. They do anterior approach. They use an inguinal incision. So in that kind of case, I had a recent experience where one of the patient coming for acetabulum repair, the surgeon used an inguinal approach, incise at the inguinal region. So I give the patient a PENG block and a TAP block. Okay, because it's an inguinal incision. All right. So it's all. That's why and then nowadays people are for hip people are looking at QL block, and also looking into the lumbar ESP. So probably, but no evidence again, no evidence because lack of quality randomized control trial to justify the usage. So but these are options. And again, when you offer analgesia, you need to be procedure specific. Like if your surgeon is gonna incise, where the surgeon, you need to find out what technique your surgeon is using in order to get the best, to provide the best peripheral nerve block. Yeah.
Hi, Dr. Ng. I have a question for the popliteal sciatic nerve block. Exactly where's the place for the LA injection? Should we inject when the nerve starts to separate or when the nerve they come in a bundle? Where's the best spot for the LA injection?
Yes. Good question again. So where to inject in the popliteal? Actually, you can inject where the nerve has already joined together as one. You can also inject where they have separated. Yeah, because like I mentioned just now in my presentation that actually both the common peroneal and the tibial nerve, when they start to divide from the sciatic nerve, they are still joined in the same sheath. So your objective is to get that sheath. When you catch that sheath, the LA will spread to the nerve. Yeah, and then sometimes, yes, I do my own modification also. Sometimes I inject where the nerve has already divided. Then I give the injection, I go from lateral to medial. So from lateral, your needle will pass the common peroneal nerve first. So I pass my needle underneath the common peroneal nerve and leave my needle inside the sheath and inject and see the spread to both the common peroneal nerve and tibial nerve. You can also inject at the popliteal crease also. Because if your surgery is really at the ankle and foot, you can inject at the popliteal crease also, but you need to do separate injection. 2 common peroneal nerve, 1 tibial nerve, 1. The easier one will be when they have already joined above. So you just inject at the sciatic nerve. You just identify sciatic nerve, you place your needle below the nerve, you put about 10 cc, and then if the spread is not nice, just go above it. Okay. The problem with the sciatic nerve that I usually think is that what kind of spread are we looking at? What kind of spread? So because of the popliteal sciatic nerve is already quite peripheral. So as nerve travel from central to peripheral, the epimysium sheath, the connective tissue around the nerve become thicker and thicker. So popliteal sciatic nerve is one of the classical example of a nerve that is surrounded by a thick connective tissue. Thick connective tissue got epimysium. So when we do nerve block, where we want to target? Well, our target is the epineurum. All right, you want to place your LA below the epineural sheath. Okay, but this sheath you cannot see under ultrasound because it's too small. So under ultrasound, so sometimes when you put your needle in, if you didn't puncture if you didn't puncture deep enough, sometimes you result in patchy block, you result in inadequate spread. So for the popliteal sciatic nerve block, so you need to really look for the nerve like floating. Okay, so if you see just LA surrounding the nerve, then you can see the nerve is probably you still need to compress and to see the nerve. Means possibly there's a possibility you just inject in the epimysium around the connective tissue around the nerve only, and that the absorption will take a longer time, and not all the LA will be absorbed and result in patchy block. So you really need to have patience and really need to puncture deep, feel the pop or something lah, feel the give of that connective tissue and see, and of course guided by what? Guided by your the injection pressure. You don't want to injure the nerve, right? So guided by the injection pressure and any pain, you ask the patient any pain on injection. Yeah, that will roughly tell you how deep, whether you are too deep or you are too, and you can also use a nerve stimulator to guide you also if you want. But in my practice, I don't use nerve stimulator. I just use injection pressure. That also not the proper injection pressure gauge. No, I don't use a proper injection pressure gauge. I just use my hand to guide the force, how deep, how strong you are, and then I will watch the spread on the ultrasound. Yes, the spread on the ultrasound. That's if you see that the spread is just around the nerve, sometimes it's not enough. Sometimes you have to go deeper. So at which level you do actually doesn't matter. Because it's all contained in one sheath. Okay. I hope that answer your question.
I think probably there's another question from the online. So it's a more like a practical question. So usually for below knee amputation, will popliteal block be adequate for anesthesia? And how about AKA instead?
Okay. Yes. Wow. For this question, it's a very practical question. For BKAs, actually BKA, yes, we have done popliteal sciatic nerve block before, but actually it's actually not a true popliteal sciatic nerve block. We will slide the probe as high as possible. Like what I showed you just now. At the popliteal crease, there are two nerves, then it join together. And then after that, you will go underneath the biceps femoris and become very, very deep. So we try to, if you try to catch the nerve before it goes into the biceps femoris. Once it goes below the biceps femoris, it's very hard to find the nerve already. So you try to catch it before it goes into the biceps femoris. That is the technique we use for BKA, not the classical popliteal. If you do the classical popliteal, you find that sometimes the level of the anesthesia is just at the mid part of probably at the ankle only. Not even reaching the level where they want to cut for the BKA sadly. So not enough. So you need to you need to slide your probe as high as proximal as possible. Yeah. So probably, but subgluteal sometimes is very difficult also. Another technique that I might suggest is you try to scan the nerve just before you enter the gluteus maximus at the proximal thigh. That is another place where the nerve is actually not so deep. Yeah, because you know that the sciatic nerve lies behind where? Behind the hamstring muscle, which is the biceps femoris. So you know the muscle at the origin and insertion is very small, right? Because it's tendon. At the middle, it's very big. So at the middle, you try to scan in the middle, definitely you cannot see because it's very big. The space that is very deep. But at the tip, at the origin and insertion site, it's more superficial. So at the insertion site is the popliteal crease. So that is very superficial. The other side where you can catch it, where it's not so deep, where it's superficial, is at the origin of the biceps femoris muscle before it enters the gluteus maximus muscle. Yeah, we can show you during the practical session later how to trace the sciatic nerve. Okay, yeah. So yeah, next question is for AKA. AKA actually is even more difficult. Yeah, actually AKA, yeah, you need to block the lumbar plexus plus the high sciatic. Like what I mentioned just now, you need to block the whole lower limb. Actually. So in the end, just do spinal or epidural. Because if you really want to do peripheral nerve block, yes, we have in HKL, in our experience, we have done before. We block the femoral, we block at least a subgluteal sciatic, and also to cover the small nerve, we also block obturator and LFCN. Yeah, we have done AKA with using 4 blocks, 4 peripheral nerve block before. Yes, we have. But the normal AKA, not the high. Some in certain condition they need to do like tumor, they need to go very high. That one, no, sorry, I don't think it covers. You need to block the lumbar plexus plus the sometimes the sciatic nerve also don't cover, subgluteal also don't cover. So yeah.
So another question. For sciatic nerve block, can we pierce the epineurium? If yes, how to know if we pierce it and not the perineurium?
Yes. Like I mentioned just now, the target of nerve block is actually, theoretically, they'll tell you pierce the epineurium, but in practical, the epineurial sheath is measured in micron. So you cannot see one. You cannot see under ultrasound. Your ultrasound, the highest resolution you can get is in millimeter only. So sorry you cannot see the epineurial sheath under ultrasound, but you can use other parameters to help you. You can see the spread. You can see the nerve floating. You can see like the nerve expanding under ultrasound. And then you have to be aware that giving proximal nerve and distal nerve is different. Because like I mentioned just now, proximal, the nerve just came out from the spinal nerve, is part of the spinal nerve, just came out from the spinal nerve. The connective tissue surrounding the nerve is not so thick. For example, if you scan the interscalene, you see it's all black because it's at the root. There's a high content of axons, not so much connective tissue. So under ultrasound, it's black in color. But as you go more distal, you find that why the nerve change become mixed hypoechoic because there are more connective tissue. There are more there's less axon probably, and then there's more connective tissue surrounding. So it become a mixed hypoechoic. But what can you see? You can see the connective tissue that surround the nerve, the muscle layer, the epimysium. So what we do is actually we try to puncture the epimysium that surround the nerve. So, and then you watch the spread. And also, you need to guide by either a nerve stimulator, injection pressure, and patient themselves, whether they feel pain or not. During injection. So, that's how we guide. So, for the popliteal, yes, again, back to the same thing again. Popliteal sciatic nerve block, we need to have the background understanding that there are thick connective tissue surrounding it. So maybe you need to go a bit deeper. You need to puncture a bit deeper. Not like the brachial plexus. You see, you puncture a bit deep, patient pain already because you already touched the nerve already. Maybe at the popliteal sciatic, you need to puncture a bit more deeper. So, but you really cannot see lah. You cannot see the epidural sheath. Cannot. Okay. All right.
Okay, probably this is going to be the last question. Is there a role for block for post-operative pain, like for example, giving a fascia iliaca block for patient going lower limb surgery but under spinal anesthesia?
Yeah, very, very good question. Very good question. Yeah. Yes, the answer is yes. If for my personal opinion and also from the guidelines, yes, even if you give your spinal, you think, but the spinal doesn't last long. The spinal doesn't last long. Probably by 1-2 hours after the operation, at the hip joint is going to wear off already. The spinal effect on the hip joint is going to wear off already. You need something that can last longer. So you can combine a block with the spinal. Yeah, you can combine the femoral nerve block with the spinal also. Yeah, people are worried that you might injure the nerve, but then you do it before you give the spinal also can, or you can do it after you do give the. But if you are concerned of nerve injury, but now you're doing a fascia. If you are doing a fascia iliaca block, then you don't have to worry because fascia iliaca is a plain block. The basic concept of plain block is you're injecting a LA into one plane, and hopefully that the spread of the LA will go to one of the nerve at another site. So it's actually indirectly. You don't puncture the nerve. You don't put the needle on the nerve next to the nerve. No, you put it in a muscle myofascial plane, and hopefully that by giving large amount of LA, the LA will go and block the nerve at another site. So yes, if you have your surgery is done under spinal, it is recommended that you give a fascia iliaca block post-op to provide better multimodal. Like I said, now our trend is going towards procedure-specific, multimodal, opioid-sparing analgesia, and to promote early mobilization of patient. So then there is a role for blocks. Of course, the evidence is still out there. Yeah, we don't have very, very strong evidence to say that more must do. If you don't do, outcome will be not good. No, but then we know that the concept is there. The concept is there. Yeah. All right.
Thank you very much, Dr. Ng. Okay, so we'll take another quick break for today. For about 50 minutes. We'll come back in around 11:30. Okay, thank you.